Good morning, everyone. On behalf of the company 3D Surgical and my segmenter, and all of us here, I extend warm welcome to all the participants. Thanks a lot for taking out the time from your schedules, and we are very thankful of you to attending this webinar where we will be talking about how the latest technologies in images segmentation is shaping the academia as well as the complex personalized healthcare. To facilitate this conversation, I have eminent panelists with me. We have Dr. Kishore Lakshmi Narayanan, who is Associate Professor at the Shine School of Engineering at VIT. Uh, welcome, Dr. Kishore. We are thankful to have you today for our webinar.
Thank you for having me, Tara.
Yeah, and on the other side, we have Dr. Suraj Hindeskere, who is lead consultant for musculoskeletal oncology at Sparsh Hospital, Bangalore. Welcome, Dr. Suraj. Thanks for taking out time and accepting our invitation as panelists to you both.
Good morning, everyone. Thank you. Thanks, Dhaval, for the invitation and the opportunity.
Yeah. So, as you know, you all must be aware that in this webinar, we would be a little bit deep diving about how the latest technologies like images segmentation and 3D visualization and 3D reconstruct are taking their ways deeper into our lives and what is happening on the surface of academia as well as in the medical hospital side and critical care side. So this webinar will facilitate Dr. Kishore's view on how these technologies and the software tools are integrated into academic landscape, and at the same time, Dr. Suraj would share his insight about its use in complex surgeries and all. So yeah, Dr. Kishore and Dr. Suraj, though I have shared a little bit of your introduction, now I would like you to share some insights about your work and your experience so far. I'll start with Dr. Kishore. Yeah.
Yeah, so I have a PhD in biomedical engineering, and I've been working at Belur Institute of Technology, VIT, for the past 6 years. And we just started a new School of Health Science and Engineering, last year. And yeah, I've been the first faculty to join the school, and we have a few more faculty now. This course is a mixture between biomedical engineering and clinical engineering. And one of the first labs we set up for this course was the anatomy and physiology lab. And the key feature in that anatomy and physiology lab is a dissection table with a huge touchscreen that has been given to us by a subsidiary of my segmenter, and that also comes with the MySegmenter software and, of course, the software itself. So last semester we had a really, I would call it really informative and new kind of approach in our anatomy and physiology lab, where our students got to experience both the cadaver as well as the MySegmenter. They got to see how the human body works and not just learn it in as theory in class, as well as learn some real life skills like segmenting out CT, MRI images and making your own meshes. And they even got to the point where they could 3D print something that they could segment. And this was all after a session with Daval, of course, who taught all our students how to use the software. And we have identified a couple of experts as well. And my background is in brain-computer interface and VR AR technology, and we are building softwares to view DICOM images in VR so that doctors no longer have to just work with 2D slices or even 2D screens. Instead, they can wear a VR headset and view the uh, digital twin of the patient as a 3D object.
Okay. Well, that's a very intriguing line of learning, and thanks for your generous acknowledgement, Dr. Kishore. And yeah, so it's I'm like just speechless about how advanced you're leading at the Shine, and I must say that when your students would be graduated from the Shine, they would be uh, laced with the practical skills and technological adaptation that the modern critical care would require. Now, as we also know that the critical care and complex surgeries are moving more and more towards the personalized care and customized implants. And uh, in our network of doctors, there is no better one than Dr. Suraj, who has been using these technologies at greater intent. So yeah, over to you, Dr. Suraj. Can you share a bit about yourself?
Yeah, sure, Devan. So I'm basically an orthopedic surgeon, and I've been trained in treating patients with bone and soft tissue tumors. So I'm basically an orthopedic oncosurgeon. So I handle only patients with bone and soft tissue tumors. So yes, 3D printing, segmentation, and all these things I've been interested for quite some time. Actually, 2016, I still remember 2016 was the first time when we started using segmentation and 3D printing for our patients. And it's actually for the first time in my previous hospital in 2016, when we wanted a 3D printed implant, there was no companies here in India to give us that, and then we had to import it from Germany. And just in a decade, less than a decade, it's really nice to see how much of an how much advancement the field of 3D printing in medicine particularly has done in such a short span of time, where we have reached a stage where we can get custom-made implants, for example, at a fraction of a cost at a very fast pace. So yes, I've been using 3D printing and segmentation for quite some time. Recently, we have also started trying out VR surgical planning for some of our complex patients. And if in case you don't know, 3D printing is a technology which is extensively used more so in orthopedic practice. And because I practice orthopedic oncology, I've had the privilege of trying around and trying to play with this technology as much as possible. And it is great to know that there is something to learn every single time. I've also been formally trained in 3D printing as well. Just last year, I was in Korea for some time, and it was a UICC sponsored fellowship program for 3D printing in orthopedic oncology. And I really hope that we reach a much better stage in the future. And recently, just sometime last year, our hospital started its own in-house 3D printing lab at Sparsh Hospital. So we are basically a chain of hospitals. We have 5 centers here in Bangalore, and the sixth one coming up in a couple of months. And we were privileged again to team up with Jajal Medical, which is again a subsidiary of My Segmental, who kind of helped us to set up the 3D printing lab in-house. I'm sure that we'll be talking about it, which has helped both the doctors and our patients significantly over the past few months.
Great, great. So great to see that such a deep experience for 3D printing, especially using in medical care. So, I'm really excited about this session that, at one hand, we have, a very well-versed academician who is versed with practical skills. And with the other hand, we have Dr. Suraj, who is greatly accustomed with this 3D technology and use of this technology at such a deep level. So, I believe that the audience would have frenzy of information here today during the next 30 or 40 minutes that we talk. So yeah, I'm already excited about it. So just to brief to our attendees, that now on we would be asking some of the question to our both panelists, and we would be answering the question in a way that they would be sharing some of the vital information and tricks to us. And in the meantime, if you have any questions, feel free to drop them on the chat box. At the end of the conversation, we would like to take your questions in a chronological manner. So, without much of further ado, would start with the questions that I have that would help us to gain some more insights about your experiences and how my segmenter and the lab that which we have incorporated at your place are helping you. So, my first question is to you, Dr. Kishore. Since you have shared a lot about Shine being, technologically advanced School of Engineering, so I would like to know that what had prompted you to integrate these modern techniques in your curriculum, which is generally perceived a bit of eccentric towards when it compared to the typical mode of education in engineering.
Well, that's the point of being a new school, right? We get to try out new things. And the idea behind the school was to give, from day one, give the students real practical experience. I'm going back to the anatomy and physiology course that we have. Um, Previously, in other schools, in other departments here at VIT that offered anatomy and physiology, it was always handled by one faculty who probably has a background in biomedical engineering like me or any other science. But we did things differently by having more than 40% of the syllabus covered by actual clinicians. And that kind of puts things into context. So anatomy is anatomy. The human anatomy is what we teach, uh, and that information was still given to the students. But what was the difference here was that they also got to know how exactly disease models works and what exactly do the doctors look for. Where do they hit a brick wall when it comes to diagnosing, knowing what is wrong with your body with the current technology that we have for diagnostic instrumentation, diagnostic imaging. So all that puts this into context. So the students are able to think from this course, like, how can I help them out? How can I bring about new technology that can help clinicians? So that was the idea behind it. And so for them to learn and appreciate the human anatomy, it's not just enough that we show things on a slide.
Yeah.
That's one of the key reasons we got the cadaver table, because that has a high resolution 3D model inside, and you can zoom in, dissect it like a real body, and take out the organs and study them in detail.
Great.
And okay, so now you've got the anatomy course. It's taught by clinicians as well as engineers.
Mhm.
Then you have really good 3D models of the anatomy. Now what? This should not just stop as a theoretical knowledge. How do you utilize this knowledge? So that's when we had the workshop with the My Segmenter, because we want to give them a taste of real practical and something that is in demand skill set. So
Yes.
once they and that little training session you had with our students opened up a whole new world for them. So they now know not just how CT MRI works as in a theory, but they
Mhm.
actually worked with the CT DICOM images. They saw how the different planes look like. They saw how what kind of information you can extract from it. How do you do segmentation? How do you look for the regions of interest? And then how do you take out a mesh? Now the students have started to think about what can I do with this mesh? I can 3D print it. Okay, what kind of other like say implants
Mhm.
can I design to work around this? Or what kind of disease models can I simulate in this? So now they have started thinking along those lines. This is a summer break, so they have started approaching us with projects. And yeah, so that little exposure opened up this whole new world. So that also encouraged us to keep doing more and more sessions, more advanced sessions, and make them all experts in this software.
That's great to hear. I mean, it's very beautiful to see that just a small session has been this much beneficial. And at the time we had the session, we didn't realize that the impact it would carry in the future. So it's like it's proving that you never know what you are creating while you're working.
Mhm.
And I'm sure whatever the stuff you have said, that interacting with the digital anatomy twin, your students are learning how to model different diseases, and they are learning how to design different solution and different patient match implants and all. They are learning at the school level, and I'm sure Dr. Suraj would be very happy to hear all this, because he would would like to see this kind of skill nurturing in our country. So my next question to you, Dr. Suraj, is since Dr. Kishore said the word digital anatomy twin, so I would like to know from you that how has the ability to interact with the digital twin of patient anatomy, meaning beyond just viewing the scans, and not just viewing the scans, but how to you interact with the digital twin of that particular anatomy at hand has helped you in your surgery preparations.
Yeah, yeah. Before that, it's really exciting to know what Dr. Kishore was talking about. I really envy the students of these days. Actually, when I was doing it, when I was in medical school, we had just come to the era of PowerPoint presentations. Most of our class lectures were on the blackboard, and then PowerPoint presentations. I'm talking about how we were taught anatomy, apart from the dissection classes, had just come up. So that itself was a great deal for us while learning anatomy, and now the access of a digital dissection table to the students where they can actually dissect any organ, dissect any system, zoom in, and then understand its relation with each other. It's great. It's really nice to know
Of course.
that we're at such exciting times. And clinical perspective of a digital twin, how has it really helped us? One, it has not only helped me as a surgeon, it has also helped the patients and the hospitals as well.
Oh,
Obviously, for me, it has helped in rehearsing my surgery, understanding the anatomy better. Even if we do the same surgery again and again 100 times, maybe for the 101 patient, the anatomy might be slightly different, or the tumor itself might be slightly different. There can be some variation in how they present to us. There can be variations with respect to how much of tumor we have to remove or bone we have to retain and all those. Basically, every body is different, right? So for
different.
me,
Yeah.
the digital twin, traditionally we are used to looking at the CT scan and MRI scans on the computer screen. Again, there are a lot of functionalities and things which we can understand with them, but having a 3D segmented model of the same MRI in a computer screen in front of you, or in the form of a 3D printed model in front of you, especially while doing the surgery, it's of great help for the surgeon. We get to orient ourselves to the anatomical surrounding much better. So that's how it's helped me as a surgeon. For a patient, actually, I always try to get the segment model segmented and keep it in the OPD room before I counsel the patient for surgery, because it's a lot more easier for me to counsel the patient with the
Mhm.
model in front of me. Just to give you an example, I hope you can see this. Yes, so this was an example
Yeah.
of a patient with a tumor in the small bone of the hand, which was very close to the vessels. These are the vessels
Mhm.
which you can see, the one in red. So it required a very complex surgery where we tried to save the vessel and then remove the tumor. Obviously, I can explain all these things to the patient on the
Mhm.
computer screen, but just imagine showing this to the patient. They understand the complexities better. They appreciate it, because they are kind of being involved in surgical planning. And finally, for the hospital, what we have noticed is the feedback and the compliance from the patient is much better when we involve them for surgical planning, when we show them all these things, even because they feel that they've been given a lot of information. Sometimes, rarely, it can also work as a double-edged sword by giving them too much of an information, but that we learn with time. We tell
Of
them,
course.
we can obviously tell them what's needed and what's not. So this is how the digital anatomy has helped. We need not necessitate a 3D printed model all the time with us. Even the same thing on the screen would be good enough most of the times. But if it's a possibility, then we can always get it printed and use it as well.
Okay, that's really great, and I mean a great thing that you pointed out that you are using this for patient education as well, which is in our experience as an industry working in this span of customized care and critical care, we generally experience that patients are not educated that because they are not understanding of these all medical technical jargons and all. So I guess this is a really novel use that you have put to this technology in educating the patient. So, yeah, I mean, it's great to see that how one thing is, we had started this with helping the surgeons, and now we are very happy that the traction is getting in terms of other aspects, being it academics and the patient education and all. Interestingly, the model just you showed, Dr. Suraj, for our attendees, could you a little bit elaborate on what tools you have used to prepare the model and what are the printers that you have used to print it and overall process just in quick manner?
Yeah, for me to come across a good, successful model, three things are important for me. One, the imaging has to be good. We need
Of
good
course.
MRI scans or CT scans, whatever we use for segmentation, that has to be good because our model or the print is as good as the scan itself. So second thing, segmentation. Segmentation basically for people who don't know is basically extracting those information from
Mhm.
a CT scan and then making it into a 3D model because a scan will have if you take a scan of the abdomen, it can have the organs, it can have the intestines, liver, kidney, bones, it has everything. For the computer to understand what is the liver or what is the bone and to extract only those information, we need something called a segmentation. So obviously, my segment is the software which we have been extensively using for the past couple of years, which is used to extract this information. So in this case, for example, so we fed the my segmenter the entire CT scan of the hand. The mind segmenter needs to understand, okay, that this is the bone,
Mhm.
this is the tumor, these are the vessels, which is important for me. The
Yep.
muscles might
Yep.
not be that important, the skin might not be that important. So it extracts
Mhm.
those information and then creates a 3D model on the computer screen. So this is the second part where segmentation is very important. The third part obviously is the post processing of the segmented model where we sit and discuss with the engineers as to okay, if this is right, if we need something else, something has to be added, something has to be removed, and finally printing it using different printers. So we at our 3D lab have monofilament PLA printers as well as polyfilament PLA printers,
Mhm.
apart from
Mhm.
resin printers. So depending
That's
upon
great.
our need, we see which kind of a printer is needed and we use it for printing the model.
Oh, that's very interesting process. Thanks, Dr. Suraj, for elaborating this. Now again, let me go to Dr. Kishore. Dr. Kishore, you said that before I go to the next line of questioning. I would like to a little bit know about. You said that 40% of your faculties are comprises of the actual academicians, right? Sorry, actual clinicians. My bad. Pardon me. Is that correct? Yeah.
No,
So
yeah, go ahead, go ahead.
yeah. So my interestingly, I have a question. Is like clinicians are so much well versed with the practical knowledge, and they are so much fast paced when they are teaching or when they are adapting, and students, of course, they will have their own learning curve. So I'm a little bit curious to know about that. How you are tackling that gap, of course, with the integration of these technologies. You could share some insights on that.
Uh, so let me try to understand the question.
Yeah.
So, I mean, clinicians, yeah, they're always on. There are two ends to it, yeah.
Yep.
Um, uh, but let's assume the fact that, yeah, most clinicians are looking for some sort of technological innovations. There are other clinicians who would like to stick with the age-old method. If it
Yeah.
works,
Yeah.
yeah, if it's not broken, don't fix it. So that kind of an attitude. But yeah, we are concerned about people who are adapting newer technology. So that's the thing. That's the reason we had clinicians come here and handle these courses, and we plan to have all our courses being handled by to some extent, depending on the course. Now, I wouldn't expect a clinician to handle like 40 percentage of course, say something like signal processing. That's
Mhm.
a engineering. But we will
Yep.
have some clinicians come give us context on how these kind of signal processing is used in their diagnosis, like EEG or even ultrasound, not the imaging part, but the actual signal part, how you can take that and diagnose stuff. So with that, uh, idea, it's to put everything into context again and
Mhm.
again. Like
Mhm.
everything that you learn here has a real life application.
Mhm.
And if you're interested in it, you can delve deeper into it.
Of course.
That's the kind of exposure we want to give the students so that they understand what are the upcoming technology. And they should never have this question, why am I studying this?
Mhm.
Like that question should never go unanswered.
Yeah.
So it's
Of course.
always in context, like these have real life applications and these are how clinicians are going to use it. If you make any innovation, you always keep the clinician in mind because there's
Mhm.
always a gap between what an engineer innovates and what the clinician actually needs.
Actually
They
uses.
see
Yeah.
patients in and out every day.
Yep.
Something that might be very uh, that might not even come across our mind as engineers would be
Mm-hmm.
very crucial for a clinician.
Mm-hmm.
Uh, these are this can start with even something very basic. Um, like going back to this module that we are developing, which is a VR AR module for loading DICOM images and looking things in 3D. Now, for let's say cardiac surgery, we thought we will build this whole array of 3D model of stents because 3D model
Yep.
of stents are easy to come across.
Yep. Yep.
You make them, you add all these physics elements to it so that you can compress it and like do all that. Now, the clinicians, while they appreciated the actual visualization of the DICOM images in 3D and they were able to do that, they had tons of comments on this stents
Mm-hmm.
like you and logic dictates like wait, you have these tents, this is how you use it, and this is how we have implemented the physics to it. So that's the engineering mind. You look at the real world and you try to approach it in a logical sense, and they
Mm-hmm.
were like yes, but we know that we are not actually working on a patient and this is just a visualization, and there are tons of stuff that you need to make to it so that
Mm-hmm.
it feels like you're actually taking it, compressing it, and doing it,
Yeah.
not doing it with a couple of options or a button clicks. See,
Mm-hmm.
that's how we work. That's we celebrate Jugaad, right? So yeah. So for us, yeah, you just have to press this button to compress it. No, you want actual hand tracking, and you want to take it and compress it. That's
Compress
how
it.
we do it. We don't want to adapt to this because then that's going to interfere with all the learned knowledge and muscle memory that
Mm-hmm.
we have with handling this. So that kind of gap, I'm realizing personally when working
Mm-hmm.
with clinicians. And I
Mm-hmm.
want all the students here to also understand that and start, when they approach a problem, start thinking on the other side as well,
Other side.
how it will affect how the clinician works. Because although we say that clinicians are ready to adapt newer technologies, the technology shouldn't be a hindrance. Now, they don't
Mm-hmm.
have time to adapt to any difficulties in the technology. Because I'm sure Dr. Suraj would also agree to it that they see tons and tons of patients like every day. So if the technology is going to be a hindrance, if it has
Mm-hmm.
buttons or controls or some sort of visualization that you have to do a couple of things before it gets ready, they would rather not use it and
Not
just
use that.
use what's existing. So to bridge that gap, we need to have constant touch with the clinicians so that the students understand what they need.
Oh, that's really insightful, Dr. Kishore. Thanks a lot for elaborating in detail. And interestingly, you are saying that your students are utilizing this and they are training and they are creating models and all. So I would want to know that how you are designing your curriculum, including these technologies, and how you are using this to their evaluation, like in grading in their exams or
Yeah.
credit course, and also how you are integrating this and transforming into an actual academic process at a
Mhm.
university level.
So, right now, in the last semester, we used it as part of our curriculum in the anatomy and physiology lab. We had
Mhm.
an exercise in the lab experiment where they had to load DICOM images, view it, and then segment it out and show us that. And we
Mhm.
picked out the best ones and we 3D printed them and gave it to the students. That was just the beginning. That
Mhm.
was just the beginning. That their first years, they were just coming into terms with how this course works and all that. So we didn't
Mhm.
want to overburden. Now, what we have planned for them in the next upcoming semesters is that we have a course on medical imaging. So
Mhm.
they need to know how CT MRI imaging works. What is Hounsfield unit? How does that affect what you visualize on screen? How can you adjust the window width, window level, and all that? All these tools are crucial for in my segment, and that's like an easy access way for them to you just don't learn what Hounsfield unit is theoretically, but you actually quickly load. this DICOM image and adjust it, and then learn, oh, this is what it means when I keep window width at 1800 and window level at 600. I'm able to view the heart. If I adjust it a little bit more, I will just see the bones. Or if I just want to visualize the lungs. So that's that's in medical imaging. Then comes signal processing. Then comes we are even planning on giving an elective on image registration, image segmentation.
Nice.
Of course, image processing that goes without saying. So we just had a taste of the good stuff, and we want to incorporate it more and more into their curriculum.
Okay.
And going back to my point, this is a highly desirable skill, and it
Mhm.
is hugely in demand. Working with DICOM images, being able to segment it and taking it further for image registration, where you take CT, fluoroscopy images and do live
Mhm.
integration so that you are able to view, like overlap your DICOM onto the patient's actual anatomy
Actual
during surgery.
anatomy, yeah.
Those are not dreams anymore. Those are going to be available in the next few years, and we want our students to be on that cutting edge, innovating these kind of technology.
Okay. I mean, that's really great that how you are integrating this into curriculum, and actually, students are compelled to learn this because it is also tied up with their grading or mid semester or end semester exams.
Yeah.
So yeah, of course, I see that the future is very bright as far as medical technology goes in the Indian landscape. Thanks, Dr. Kishore, again for such an elaborated answer. Now, again, a couple of questions for you, Dr. Suraj. So, uh, Dr. Kishore has said that they are, using AR, VR stuff and as well to visualize their anatomy. And you had also said that you are also use some of this AR glasses and VR glasses. So, could you share a bit of experience about that? And I'm to what I preserve, that technology is still needs a bit of reshaping when it comes to its form factor of those big glasses. So not only the benefits, but I also want you to share your hurdles, or share your some of the things that you don't like about that technology, or in the whole this technological integration that we are discussing today. If you could point out some of the things that you would want us to improve.
Yeah, yes, we have been playing around with VR and AR surgical planning for some time now. It's relatively new. So first, when we started using the VR surgical planning by my segmenter and a few other companies, the problem was it was just a glorified monitor, a computer screen.
Mhm.
Obviously, we could see the 3D models much better. We could walk around it instead of turning the 3D model, zoom, pan, measure. We could obviously do all those things, but to be honest with you, VR didn't give too much of an additional information to me as a clinician than more than a fancy computer screen. But AR, yes, there were a lot of more advantages, because in VR I can't use it while I'm operating,
Mhm.
because I can't see the patient on the table. So AR that way was slightly more better, because let's say I'm operating, I had to look at the patient's MRI scan or the CT scan instead of walking all the way to the computer screen. So like someone could put the goggles, and then I can see the patient in the background. I can also kind of rotate and see the 3D model right in front of me. Though practicality is like still limited, but AR surgical planning was way more better than VR surgical planning. But the negative aspects is it for me, again, as a surgeon, it does not help me a lot to perform the surgery much better unless I'm able to register the 3D model on the AR goggles onto the patient who is actually on the table. So a lot
I
of
see.
companies have been working on it now. They're trying to some companies have been trying to freeze the 3D model in a
Mhm.
position where the patient is positioned on the operating table, so that the anatomy kind of matches. That is one way of doing it. Some companies are trying to have QR codes on the patient, and then try to overlap the QR code
Mhm.
on the 3D model so that it kind of gets fixed. So it's still a work in progress. I'm not too sure how much it is going to help me while performing the surgery. Like,
Mhm.
there were a couple of projects a few years ago where I wear the VR goggles and then it is connected to a surgeon in some other city. He's able to, look at the dissection, what I'm doing, and he's able to kind of guide me if I'm doing it right, if I have to take out more tumor, less bone, and things like that. But practicality, it's not helped us in performing the surgery much better. But planning wise, yes, it's again, it's like watching a movie on a computer screen versus watching a movie on a VR goggles. It's much better in understanding. I also know a couple of people who are using it for patient education as well, where the
Mhm.
patient is seated in in the OPD, they put on VR goggles and then they showed and told that, okay, this is your spine where it is curved and this is how it's going to look after the surgery. So it's still in the process of planning. Well, helping for surgery, I think we still have some way to go.
Mhm. I see. So I would conclude from this much of information that you both have shared that AR VR is is on its journey towards the upward curve, but it's a very nascent stage as of now. I would say in terms of its use in practicality and how the impact it has when it compared to the tools like my segmenter and 3D printers that have the impact on the actual surgeries. Is that would that be a correct assessment as per you both?
Yes, I agree that there's still some where points to be ticked before we start using it for routine clinical practice, especially in the operating room. But like Dr. Kishore mentioned, it's not very far off because these are
Mhm.
just slight tweaks, and then we have the kind of technology to do it. It's just that we need to bring in match things from all around and then kind of execute it. We're not very far off. I'm pretty sure.
Okay, that's great to see because we are also doing some of the R&D work on the AR side as well. That would be, just you said, Dr. Suraj and Dr. Kishore, that would be solving the hurdles of where patient's anatomy gets logged and models is actually visible while the patient is on the OT table, and that would give you more practical insights about to tackle the surgeries. So while in we can conclude that now we have reached to a level technologically where the digital twin of an anatomy has transformed from nice to have to must have stuff when personalized care or complex surgeries needed to be taken care of. So now until now in this session we were having kind of two separate flow of the conversation where Dr. Kishore was saying about his experiences in the academia, and Dr. Suraj, you were giving your insights on the medical aspects of that technology. So now I'm trying to, bind the two, and if I add ourselves as well from the industry aspects, so all three of us, I would now like to bind into a common conversation where we can discuss something. So my thought are, suppose Dr. Suraj, you are creating a team of engineers. If you have the scaling up of the patients, and patients are coming for asking the complex care more and more. So you now have to develop your own team of engineers and clinicians. So what could be the attributes that you would appreciate in them that they should have before you hire them or you form your team and they start using this technology? I mean, this could be some of the insights for Dr. Kishore, and they can in turn we can integrate it in our technologies and work life that would support you more.
That's a very important bridge to be gapped. I was very happy when Dr. Kishore said that most of their faculty members are clinicians, so that they get a real world use case scenarios about the things which they are developing. Most of the time, there's a huge gap between the doctors and the engineers, which they it really have to be bridged. I've been fortunate enough to work with our engineer Sukrit Kumar. He's from Jajal Medical for almost 5-6 years now. We both kind of started started using 3D printing at the same time. He was just out of his engineering school, and then he was, trying to learn segmentation and 3D printing and things like that. And even I was in that learning phase. So the fortunate thing was, like, we have been working with the same team, same engineer, same company for quite some time. So we can always get back to each other and tell that, okay, this is what I want, and then they can come back and tell us that, okay, this is how it is. And to give you an example, initially when I used to print the 3D jigs cutting guides for bone tumors, let's say that I'm comfortable with one person or a team. So they, even before I could start the discussion after sending the scans, they would prepare a guide because they knew that, okay, this is the saw which I'm going to use, this is the cut which I'm going to take. This is the soft tissue extension or the bone where the jig sits. All those things were kind of understood. So I didn't have to tell all these 20 points to the same, the engineer who is designing the cutting jigs. So that solves a lot of problem if you're kind of well acquainted with the engineer or the team. Second thing is, I think that it is, in fact, for me, it's a compulsory thing for Sucrit to come and assist me in the surgery when I'm using the 3D printed cutting guide. Because again, on the computer screen, it looks nice and shiny, looks fine, looks nice, colorful. But then when I'm trying to fit it on the patient, we might think that, oh, okay, here it could have been a little more, here it could have been a little less. We understand a lot of practical aspects on table on the patients in the operating room. So our engineer always accompanies me for the surgeries which I perform, for the jigs which he has designed for me, so that we know what's right and what's wrong. And after the surgery, we kind of come back and then discuss about how the same jig or the guide could have been developed better. We write down 5 points and then try to work on it. So, and he also gives me some ideas, because those things wouldn't have occurred to me, that we can actually design it in this way, we can try to anchor the jig in different planes. Those things wouldn't have occurred to me. I'm more oriented about removing the tumor, because those points can only be taught by an engineer, or thought and taught by an engineer, which we don't understand, wouldn't even thought about. I'm like, oh yeah, why can't we try this? So that's him. I feel that it's important for the engineer to also assist in the surgery, or while using the, let's say that they're developing a VR software and the clinician is actually using it on the patient. It's nicer if the engineer is also involved. I feel that this bridge has to be gapped, and I'm happy that VIT has such courses, which I'm sure that are working on solving all these issues, which have been quite significant for some time.
Well, that's really great. I mean, it would be a great some skill sets that you had just explained that you would want an engineer to have, and I'm sure Dr. Kishore would be very happy to take this point. And not just the medical and industry, Dr. Kishore. Now, I would also like to know from you as well that while the medical fraternity and industry expects the students to have this insights and this skill and all, but I would like to go one step ahead of it. And what would you want from us as an industry and as a medical fraternity, that with our integration with your institute and with the academia, what would you want from us, so that you can shape the future of India, which are the students basically learning at your institute?
Uh, to put it more bluntly, more job opportunities for our students. Yes, that's the blunt part, but we want them to be trained by industry from the get-go, so that by the end of it, they have these desirable skills that the industry can absorb. So,
Mhm, mhm,
to answer it in a full manner, we want the industries to invest in these students in
yeah,
colleges by in through internships, through workshops, through giving them access to these kind of high-end software and technology and equipment, so
mhm,
that I mean, this is how IT works in India, where they study for 4 years and then they sit for the campus interview, and they're judged by what they learned in that 4 years alone.
mhm, mhm,
And then once they join the job, that's when they have a training period where they orient them into learning what they are going to be doing in their career for the next few decades.
mhm.
That model has to change.
Of course.
We are open to have the industry come here and tell us what are the desirable skills out there, and invest in these students, and which I'm very happy that my segmenter and Judge Medical were able to do with our Shine students by investing with the cadaver table, and as well as giving us access to this software so they can learn. And now the next step would be we train them along with you, and then we send them for internship. They learn how a workplace works, how exactly this workplace wants me. They might or might not end up in the same company, but at least
They
the
get an
the, the
exposure.
product that we are sending out at the end of 4 years are like really industry ready.
Yeah, of course. That's a great part, and we are, all committed to, work with the academic institute and kind of become the bridge between the two ends of this process, whereas one is medical hospital, medical establishment, and the academia. I'm sure Dr. Suraj won't mind if 3 or 4 requests for an internship goes to the Sparsh 3D printing lab, and he would be more than happy to train some of the students.
Yeah, definitely. It's not only about training. It's surprising to see how much of things I'll have to learn from whatever exposure or experience they have had. It's always two-way. Yeah, they definitely. If it's opportunity arises, I'll be more than happy to host them. And another thing is like Dr. Kishore was telling, it's really promising for even the students while they're doing the course. If they know that okay, there is quite an opportunity outside, there is a lot of opportunity, just that in the medical fraternity the awareness is still not reached in terms
Yeah.
of segmentation, 3D printing and 3D planning. Very few of the clinicians actually use it in the clinical practice, which is kind of sad. Maybe some cardiology and orthopedics are a few departments which routinely uses it, but there's definitely scope, but that awareness is not there in our hospitals. I always try to give talks and then tell them about how our 3D lab works and what we do and things like that. But that barrier where a clinician actually puts in effort to use this technology has to be broken. A lot of people feel that no, I've not been using any of these for quite some time. I'm happy. I'm still able to do my work. Why do I need this? Why should I waste time on this? Is it's an assumption by a lot of clinicians, but we're definitely trying to break that barrier and then help them to use it one step at a time.
So I'll take that feedback for us, the industries, as because what Dr. Suraj said, that it is kind of an action item as an industry for us to bring more awareness in the market with
Yes.
expanding our centers and expanding our operations more and more, so that more academicians and more users of this technology can take the advantage of one another, because whatever the technology we are using today, and it's landscaping the complex care and personalized surgery and all, at a point of time there were some ideas in the mind of a student back then, and then from that point onward those ideas got nurtured and transformed into these kind of technologies. So yeah, let's say now, this while this conversation is never ending and I'm so much into this conversation, I would desperately want it to go on and on, but we also need to have a look at the time as well. So I would not say end, but I would say that we are pausing the conversation here, and we would be doing much more such webinar in the coming time, where would be touching upon different topics in this medico-technological landscape involving some other aspects as well. So here, I am very much thankful to both the panelists, Dr. Suraj and Dr. Kishore, from all on behalf of all of us, the attendees, the industry, the 3D surgical, and my segmenter. Again, I'm very much thankful for you both to that you have taken out the time from your schedules, and you shared your valuable experience with us. So with that, I mean, I would open this session to the Q&A from our attendees. If you want to know something from us, we can spare like 5 minutes more on answering your questions. So yeah, anyone can put your question in the chat, and we would like to take them in line by line fashion. Okay, while someone put their questions, I would like to, there are some obvious questions that I would like to go ahead and answer. That how to explore these tools and where these tools are available for the exploration. So this is the common question, and I am dropping a link of website in our chat box. From there, you can experience this segmentation tool, and you can be in touch with us. I'm sure you all will have our contact details, and you can reach to us on LinkedIn and all such platforms where you can interact with us, and we can try to build these kind of engagement more and more. We have one question from Armayas that can you provide resources, or do you provide online courses for self-paced learning in medical imaging, segmentation, 3D printing, and planning? I'm an orthopedic tumor surgeon working in Ethiopia. I would like to establish a team, hopefully to be based in hospital. So yes, doctor, it's very great to see that we are having the audience from across the globe. Yes, we also have the self-paced learning. If you just search 3D surgical on YouTube and you go on to its YouTube channel, there you can see all our videos, and we have very extended videos that we have put over there, segmenting some of the complex cases such as ACV junction for a cervical spine correction. Then we have congenital heart disease, where the model is being made, which is representing the large defect, large VSD, ventricle septal defect. So yeah, just log on to our website, that is mysegmentor.com, register yourself and avail the trial license. And once you log in on our portal, you will see everything, the course material, the links of different videos and all into the help section of that particular dashboard that is in front of you when you try to log in. So I hope that answers your question. And if you want to know more, kindly write back to us, and we would be happy to take a one-on-one call with you and explore the opportunities in depth. Okay, so anyone from the chat, you want to know more about anything? Any specific questions? Okay, well then it seems they will be right back to us again if they have any questions in future. So once again, we are going towards the ending this session. Again, from the 3D Surgical and my segmenter, I am thankful to all the attendees who have taken time and engaged with us in this very much intriguing webinar, which is full of information from the three pillars of different industries: academics, the core medical device industry, and medical establishment. So I am thankful to all the attendees, and once again, our generous thanks to all the panelists, Dr. Kishore and Dr. Suraj, for joining with us. We would be continue to have such conversation in future. And yeah, so that's it from our end. Wishing everyone have a good day, and looking forward to interacting with you all in the future as well. Thanks, everyone.
Thank you, Dhaval, once again for the opportunity to 3D Surgicals and my segmenter. And it was nice catching up with Dr. Kishore. Good to know that you're doing great work. I'm sure that I'll be, interacting with you pretty soon. It was exciting to know that you've been working on AR and VR as well. So I'll definitely get in touch.
Looking
Thanks,
forward to it.
Dhaval, again for connecting and
It's
for the
pleasure. It's
opportunity.
pleasure.
Thank you. Thank you all.